Hi, everyone, and welcome to Liver and Lung Mets. My name is Janine Guglielmino, and I am Vice President of Mission Delivery at Living Beyond Breast Cancer. We're really pleased to have you here today, and joining us is Dr. Ann Blaze, who is an Associate Director in the Division of Hematology and Oncology at the University of Minnesota. She is also Section Head of Medical Oncology within the division, and is Director of Cancer Survivorship Services and Translational Research within the Masonic Cancer Center. Welcome, Dr. Blaze, and thanks for being with us today.
Thank you, and thank you for having me.
Great. Well, let's jump right in. And why don't we start by talking a little bit about lung mets? Why don't we start off with the question that is on a lot of people's minds. How common is lung mets in metastatic breast cancer? How often does it happen?
Yeah, it's a good question. Typically, if you think about patients with metastatic disease, about 70% of women with breast cancer will develop lung metastases. Sometimes go ahead.
That's okay. Is it more common in certain subtypes of metastatic disease?
I would tell you that in general, if people live long enough with metastatic disease, really about 3/4 of them will develop it. I don't think of it as typically confined to one subtype of breast cancer. The one exception I'll mention is for hormone positive breast cancer, there's a subset of those women who develop metastatic disease with bone only disease. But outside of that, when we think about triple negative or HER2 positive or patients who've had metastatic hormone positive disease for a long time, I think the vast majority of them can develop lung metastases.
And Dr. Blaze, when you're seeing a patient with metastatic breast cancer who hasn't had lung metastases before, what kind of symptoms are you looking for to look into whether that person might have lung mets?
So sometimes these are picked up on scans and actually people have no symptoms. So I would say the presentation is actually quite varied. In some instances, there's no symptoms. Other times people will come in with a cough or feeling short of breath. And sometimes they can develop some almost like discomfort or pain in their chest. So when I think of like lung metastases in the lungs, and we might get to this, but sometimes they can be found sort of in the parenchyma of the lung, so meaning in the middle of the lung. Mm-hmm. And your lung can compensate it has a lot of normal tissue around it. On the flip side of that, sometimes people develop, because of that, they'll develop fluid around the lung, or what we call a pleural effusion. Sometimes they have both. But with a pleural effusion, they may really come in feeling short of breath or sort of discomfort in their chest area.
And once you've determined that someone does have lung mets, you've gone through the test to determine it, what specialists would be involved in the care of lung metastasis?
So sometimes it'll kind of depend on that presentation that I mentioned to you. So if it's in the parenchyma of the lung and somebody's asymptomatic, primarily they're probably really still seeing their medical oncologist through it. And it may depend on what the rest of their disease looks like in terms of how to approach it. Sometimes they may see a pulmonary or a lung specialist. Sometimes they'll see an interventional radiologist about pursuing like a biopsy or treatment for that area. The pulmonologist can also be very helpful if there's that fluid around the lung and we need to do a procedure to kind of drain that and help people feel better. Rarely people might see a thoracic surgeon. And then on occasion, we'll treat some of these with focused radiation, in which case they would also be seeing a radiation oncologist.
So if you are seeing multiple specialists for the treatment, how is the care coordinated?
I think I would look as the medical oncologist as sort of the ringleader. And part of that is when I see somebody with lung metastases, I really want to know what else is going on with their breast cancer. So is their disease growing in all different spaces, or is this something where there's one or two spots in the lung? And that's going to be something really the medical oncologist is going to talk to the patient about to say, where are other things at? And the reason that's important is if there's lots of cancer growing, and I shouldn't even say lots, but if it's growing in multiple areas outside of the lung only, we may say, well, let's change your systemic treatment. So let's change treatment that's going to work everywhere. That's a little bit different than if I see, say, one or two areas in the lung. And we're talking about, gosh, should we do something different with just those lung metastases that are there? And so working with the medical oncologist to help coordinate which specialists are appropriate for me to see simplifies things for sure.
So you actually start addressing my next question, which is that with such a variety of treatments that can be used for lung mets, it sounds like you start from a place of looking at the extent of disease in order to determine your first steps for treatment. But what are some other factors that you're thinking about when you're selecting treatment and the order of treatment for lung mets?
Sure. So as I mentioned to you, I'm going to look at what kind of treatment has somebody had. We're also going to look at actually in today's world, it's really important to think, do I need new tissue? So about 20% of the time when people have metastatic breast cancer and new metastatic disease, we may want new tissue to actually look at the genetic abnormalities or to look at those receptors again. So estrogen, HER2, about 20% of the time that receptor subtype will change. So sometimes we'll ask, do I need to biopsy that to get another idea of it has the characteristics of the breast cancer changed? We talked a little bit about the fact that if there's disease in multiple places, we may recommend a change in systemic treatment. And a lot of that is going to depend on what kind of prior therapies people have had, as well as the subtype of breast cancer that they had. I think the flip part of that is when you're looking at local disease where there's a couple, say, let's just say one or two areas, then we can have sort of more discussion about should we be aggressive with treating those? What are our options there?
Dr. Blaze, you mentioned that biopsying the lung met might be an important piece. Could you speak for a minute about how easy or how difficult it is to do a lung biopsy for someone who might be considering that?
Sure. In general, most lung biopsies are probably done by our interventional radiology team. So they basically, similar to most patients going through metastatic breast cancer, are well familiar with interventional radiology when it comes to, say, having a port placed. But basically our radiologist, a special group of radiologists who will give you some sedation just to kind of relax you. They actually use the CT scanner. So they'll use that CT image. They'll relax you with it. And then basically they go through the skin with a needle and direct it right at the nodule that is seen. They need the CT scan to know that they're in the right area. And then people go home that same day. There's rare complications from it. So occasionally, probably the thing that we worry the most about is in rare situations, people will develop a pneumothorax or an area where there's kind of a leak in the lung. It's more common in patients who have underlying lung disease like COPD or emphysema, but that's what typically they will watch for the most. Sometimes biopsies are done by our interventional pulmonary team, or I mentioned the lung specialist. And if you have a lung nodule that's really close to the middle of the chest, they may be able to go down through a bronchoscope and actually do a biopsy that way. So they take a scope down into the airways and then biopsy the nodule that way. So it does take some coordination between those different teams. But again, I really think of the medical oncologist as helping to kind of have that conversation with those specialists and figuring out the best way to approach that for the patient.
Sure. Thanks for answering that. I want to talk for a couple minutes about some of the specifics of choosing the local treatment or the systemic treatment, because it sounds like there's a number of options you could choose to just focus on the specific area of lung mets or to treat the whole body. In looking at local treatments, what kind of local treatments might be offered to someone and how might they look different than other treatments someone might have received for metastatic breast cancer?
Really good question. And I would tell you something that we keep getting more data and sort of keeps evolving. So I'm going to give you sort of, I think in answering your question, try to give you a few scenarios with it. The first being, how could we treat a lung nodule that has cancer in it? And then sort of telling you a little bit about the data to support doing some of these procedures, if that's all right with you.
Absolutely.
So when I think about a cancer in the lung, usually that does present as a nodular mass. When we think about that, there's a couple ways to approach it. It could be surgically resected, so a thoracic surgeon going in and sort of taking that whole area out. It could be, there's more and more data using a technique called SBRT, which is a focused form of radiation. Those are probably the most common ways that we target like a lung nodule. And then there's obviously the changes in sort of your systemic medications. One of the things when we have techniques to treat a metastases, like a nodular cancer in the lung, always the question that comes is that the right thing to do? So I gave you the scenario of if things are growing everywhere, I don't want to only treat one spot. I want to treat everything. The flip side of that is if you have one or two small areas in the lung, should we be more aggressive with one of these other treatments? If you look actually, so about 6% of breast cancers present with metastatic disease at like their very initial time set. When we look at there's been 3 large trials actually that have been done to look at should we do primary breast surgery in addition to treating the breast cancer in those. In those trials, actually, we don't see any advantage to treating people with, say, breast surgery or doing like a mastectomy when they have metastatic disease. In the opposite scenario where someone's already has had treatment for breast cancer and they have this now cancer growing in their lung, there's actually a large trial ongoing right now through the NRG, which is a cooperative group around the country, to try to get better data on, gosh, if you present with less than 5 sites of disease. So in this, let's just say 2 or 3 lung nodules, but in the trial, it's less than 5 sites of disease. Can we be aggressive with systemic treatment, but also do focused radiation to those areas? With lung nodules, this would be a very classic situation to answer that question. In breast cancer, there are reports of people doing this approach, but most of it's kind of in hindsight. So going back and looking where it's been done, as opposed to a prospective study where we actually look at one group and give them that treatment and the other monitoring them with just systemic treatment. So we're really excited in the oncology community to see the results of that trial. We don't have them right yet. So if you're a patient presenting today and you have lung nodules, I think primarily working with the oncologist and the specialist, it's really important to say, how is everything else responding? So if you have good control and now you have a nodule growing, but say you've had good control of your disease for, say, with anti-estrogen treatment or with Herceptin-based treatments, then a lot of us would say, gosh, let's be aggressive and let's go after that with radiation or with surgery. I don't think we know completely which is better when it comes to surgery or radiation. One of the challenges of that is surgeries, people can be sore and it can be a little while to recover from that. So typically I would say talk to your doctor about the best approach for that. For patients who have really aggressive disease and new things are kind of popping up more quickly, going after one nodule might not be the right choice. But certainly when things are well controlled and you have growing pulmonary nodules, then I think asking that question, should I have this focused radiation or think about surgery, are good questions to ask.
And Dr. Blaze, is there ever a situation where if someone had a single or a couple of small nodules where you wouldn't go in to treat at all, where you would just watch and wait to see how things developed?
I think There are some scenarios where so sometimes we see really tiny nodules on a scan and they're 3 or 4 millimeters. And in those situations, we don't always know, is that like infection or scarring and not cancer related. So oftentimes in those situations, we will just watch them. So those are things we may say, watch for somebody and see. The thing I always tell patients is cancers grow. So if that's a cancer, with time it will grow. And no one wants to put somebody through an aggressive procedure like radiation or surgery on something really tiny like that, when there's the potential for complications from those types of procedures. So in those situations, I think definitely monitoring and not doing anything is the right thing to do. I think the other place that sometimes will not do anything, actually this came up in a patient of mine this morning. She had a nodule on her lung that we've been watching. And I looked at it really closely with the radiologist. And it actually turns out it was really close to the field of her radiation for her breast cancer. And it actually looks like this isn't nodule like cancer. This actually looks like scar tissue or fibrosis from her radiation. So I think when I got to look at that with our team and really see that, I'm not going to recommend anything for that. This really looks like very just related to her her radiation as a scarring area and not something worrisome.
So really important to understand what's being seen on these scans and looking at the whole picture of the person's experience is important in selecting treatment.
Yeah, the whole picture is really important in terms of what does the rest of disease look like? I think the one thing I didn't mention is what kind of shape is the patient in. So somebody also with a lot of underlying lung disease, like COPD or emphysema, you can imagine any targeted treatment to their lungs might really affect their capacity to get doing things. And so I would say the history of their cancer, the location of the nodules, and then sort of the underlying person are really important things to think about when addressing these.
And when selecting systemic therapy, the full body therapy, is it primarily based on the type of cancer? Or are there other considerations or medications that are known to be especially effective for lung mets?
In breast cancer, we really look, and actually I would say for all of our cancers today, it's really important to know the sequencing or the hormone expression of those cancers. So is it estrogen positive? Is it HER2 positive? If it's negative for all of those, like in a triple negative, does it overexpress something like PD-L1 that makes patients susceptible to things like immunotherapy? It's not unique to the fact that it's specifically in the lung, but really what the biology of the cancer looks like.
Great, thank you. What sorts of symptoms and side effects might a person with lung mets experience? You talked a little bit about pleural effusion, and if you could talk about some other kinds of symptoms and how, as a physician, you would help people manage the symptoms and side effects of lung mets.
I think for a lot of people, as I mentioned, they might not have any symptoms. So that's pretty easy. I don't need to manage anything. Sometimes people will have like some wheezing or feel short of breath, in which case a physical exam to figure out if there is wheezing, could like an inhaler help with symptoms. Occasionally people can have shortness of breath or some chest discomfort. If it's a pleural effusion, as I mentioned to you, that's kind of fluid around the lung, in which case it can be drained with a needle. And that usually provides almost like instant relief for the patient. So as scary as it sounds to have a needle stuck in your lung, actually people feel better almost right away. So I think those are the typical things we think about. In really rare occasions when people have a lot of lung nodules, they may feel short of breath or have a cough, in which case medications can be given to help manage those symptoms.
Dr. Blaze, since we're in the middle of a pandemic that affects the lungs, I'm curious whether you have patients who are having symptoms and are concerned about whether it's lung mets versus COVID-19 and how you might evaluate that, or what a person might want to ask themselves if they're concerned they might be developing lung mets.
So I think in today's world, like you said, there are, if anyone's having new respiratory symptoms of like cough or fever, they really should go in for COVID tests. It's just too prevalent today to not start with a COVID test. So I always think that would be sort of step one. The other piece of, gosh, if I'm having these symptoms, this cough, I'm feeling sort of short of breath, what else could it be and not be cancer related too, if you're feeling like that? I think there's a bunch of other things that can do that. Some of the most common ones are things like asthma. So always ask, is this something new? Have I experienced this before? We're going into allergy season, which causes oftentimes people cough and some shortness of breath. So I think reflecting, gosh, have I ever had this before? I know many people who this time of the year, as the trees get ready to bud, all of a sudden they're coughing and sneezing and feeling a little short of breath. And then the other thing that, especially with COVID and the current stress right now on people, I've seen a lot more like heartburn types of symptoms, and acid reflux actually is one of the most common causes of cough. And so they think of acid reflux as, oh, I'm going to have like heartburn. But sometimes that presents actually with the same types of symptoms of just sort of cough and shortness of breath. So I typically ask people, and then there's more serious things like lung blood clots or chest discomfort where it's actually related to the heart. So if you're experiencing like a cough or shortness of breath, I would probably first ask, is this new and different? How bad is it? Because if it's really significant, you need to just go get it looked at. But if it's, ask yourself sort of, how long has this been going on? What about these other sort of simple things? And I say simple, but they're simpler than cancer in my mind from an oncologist. So thinking through, how different are these for me? And then if it's persistent there, I usually tell people anything that's new and different for you, that's been lasting over about a week and a half to 2 weeks, I want to see you in clinic. So those would be good things to then go in and get evaluated for.
Thanks so much for answering that, because we know there are probably plenty of folks watching who don't have lung mets but are worried about it. Yeah. And this will help them to think about it. Thank you so much, Dr. Blaze. You've shared so much helpful information about the approaches that you take to treating liver and lung mets. I just want to close with a last question, which is what is one thing that you would want a person going through metastatic breast cancer treatment to understand about a diagnosis of either liver or lung mets?
Yeah, so I think when somebody has liver or lung metastases from their breast cancer, I think in today's world, to me, when you're caring for somebody, it's always important to have hope. And I would say, be hopeful that there are new techniques. There are also new systemic treatments with the goal really of helping people to continue to feel well. Usually when breast cancer has spread into those other areas, the vast majority of the time, the cancer is not curable, but it's treatable. And so whatever kind of treatment you're getting, you always want to ask, how am I going to feel after this? Because I want you to keep feeling well. I want you to keep being able to do your usual things. And that I think is a really important thing. But I would say have hope, because there's a lot of new techniques. We talked today about some of the specific ones for metastases, but there's a lot of new systemic treatments too. And those are encouraging.
Thank you so much for sharing that. And thanks to all of you for listening and being with us. To get more information about liver and lung mets, please visit lbbc.org. And we look forward to seeing you again soon. Thanks, Dr. Blaze.
Thank you for having me.